Good afternoon, everyone, and welcome to this innovation webinar from the Institute for Perinatal Quality Improvement. My name is Kaylee Vitek, and I will be providing technical support for today's event, so please feel free to reach out if you have any questions. Today's webinar is called Integrating the Freestanding Birth Center Model with Hospital Services, and it's my pleasure to introduce our speakers. Amy Romano has spent her career working on maternity care system reform and innovation. Currently, she is the founder and CEO of Primary Maternity Care, a consulting services company that works across the healthcare system to strengthen community-based maternity services and integrate high-value team-based models of care. Bryn Rubenstein is a consultant with 15 years of experience building and scaling up women's health programs with nonprofits, healthcare delivery systems, and companies. Prior to consulting, she launched and led the Transform Maternity Care program at the Purchaser Business Group on Health, an initiative focused on improving birth outcomes through midwifery access and value-based payment reform. Claudia Jennings is a midwifery and birth center operations consultant with Primary Maternity Care, with over 7 years of birth center experience. She has particular expertise in contracting, billing, and operationalizing innovative payment models specific to out-of-hospital birth. Blair Dudley is the director of the Transform Maternity Care program at the Purchaser Business Group on Health, and she provides strategic leadership to promote high-value, equitable maternity strategies, including reducing C-section rates, expanding the use of midwives, doulas, and birth centers, increasing screening and treatment of perinatal mood and anxiety disorders, spreading value-based payment, and engaging consumers in care. And last, but certainly not least, I'd like to introduce Deborah Bigham, who is the founder and chief executive officer for the Institute for Perinatal Quality Improvement. And with that, I will turn it over to you, Deborah.
Thank you so much for joining us today. We're so excited for this wonderful panel to present to us. And I want to just go through the mission and a little bit of updates from PQI before they get started. So the mission of PQI is to expand the use of improvement science and in order to eliminate preventable morbidity, perinatal morbidity and mortality, and to end perinatal racial and ethnic inequities. We have a lot of work to do in our country. The US infant mortality rates are much higher than a lot of other countries. We have wide variation in our infant mortality rates. We also have high rates of pregnancy-related mortality, and the recent release of our maternal mortality rates have continued to go up in the United States, in addition to our high rates of severe maternal morbidity. Those are the main reasons why we formed the disparities that we see in outcomes, as well as these worsening outcomes or outcomes that are worse than other countries. I'm really grateful to our executive board of director for helping us supporting our efforts in the country, and also our editorial advisory board. And again, I'll give you a really quick brief update of some of the things that PQI is working on at the moment. One of our biggest initiatives is the Speak Up program, and this is founded on the recognition that conversation is where change begins, and we all have the power to change conversations. Speak Up is an acronym and a mnemonic, and it gives us several different actions we can do in order to work very diligently, we hope, on being anti-racist in the country. We also have a 28-day anti-racist challenge we just completed on the end of February. This was our third time doing a 28-day challenge. In February, we updated it to version 2 this last year. And it still lives on our website if you want to go and see the reflections, the learning activities, and the actions that we have for each day. And there are nearly 2,000 individuals who signed up, registered, and we know that many of them also had led efforts at their hospitals or in their facilities to follow these different activities. So hope you join us next February. We'll be launching again. We have a Speak Up Action pathway. It's not just enough to know what needs to be done, but we actually need to do it. And this includes three levels: the champion level, the ambassador level, and the faculty level. We're thrilled that we have over 1,200 Speak Up champions in the United States, and we hope that you consider becoming a Speak Up champion. This is a lot of steps that you take that were on the action pathway in order to become a Speak Up champion. Our next National Speak Up Champion course is in October of 2023. So you and your colleagues can join us. We would love that. In addition, we have an ambassador courses coming up. We have one coming up very shortly on April 13th and one on May 25th. And just to remind you, the pathway is champion to ambassador to faculty. We will be launching our faculty course, our first faculty course this fall. That we have online modules as well that supplement the virtual live education we provide in our Speak Up Champion program. And then the other big initiative is working to reduce C-sections and increase freedom of movement in labor. And with that, we have the intermittent auscultation course, simulation-based education, which is an online module. And we were thrilled that A1 also is working with us to put, we actually have our courses on their learning management system as well to help expand the use of this course. And Amy Romano, who is one of the speakers today, is the lead author of this module. We are thrilled that we have all across the United States. We have, and even some international learners, and this was as of June 2022. We will be updating this map because our birthday comes up in June. And so we will be putting out the more up-to-date maps shortly. But we have thousands of learners who have already completed this education. And then some of you that may have been following us for a number of years, we have been running a quality improvement course since the beginning of the founding of PQI. And it's been now refreshed and expanded to include you don't need to be perinatal only to come to this course. It's expanded to be around quality improvement essentials is the new name of the course, but it will build and has evolved based on what we have learned from our previous courses. Just a reminder that QI saves lives. We'd love to have you keep in touch with us. And thank you again for attending today's webinar. And without further ado, I am going to turn it over to Amy Romano and the rest of the panel to be able to give us their presentation today. So thank you.
Thank you, Deborah. We are really excited to get into this topic. I'm really pleased to have the opportunity to do that with PQI, and Deborah and I have worked together on the intermittent auscultation program and on many things prior. So it's always great to be back. And we'll dive into our topic. We all said hi earlier and had our bios read. So I think this is our team. And we all work together on the guide that we'll be sort of talking through and getting into some implementation ideas and hopefully some conversation at the end of this. So let me just get organized here. These are the learning objectives. So but hopefully we will have a conversation that will allow us to assess whether a hospital or health system is ready to integrate the freestanding birth center model, and then to identify the implementation tools and resources to strengthen hospital and birth center collaboration. So that's what we're up to today. And this is the agenda that we hope will get us there. We'll talk very briefly, just a little background about PBGH and PMC, which is Primary Maternity Care, my company, because this project is really a collaboration between our two organizations. And then we'll briefly talk about what a freestanding birth center is. We're going to assume some level of knowledge about that and refer you to some deeper resources because we really want to get into implementation today. So we will talk about why this is an important topic for hospitals to embrace at this moment in time when there are many other demands on hospitals as well. Why integration between hospitals and community birth settings like birth centers matter. And then we'll take a deeper dive, brief look at the guide and point you in the direction of some resources that can bring you from wherever your hospital or health system is right now to further down the path of integration and collaboration. And then we'll wrap up with some information about our upcoming open learning series and action collaborative for hospitals and birth centers that want to go deeper with this work. Blair, I'll hand it over to you.
Thanks, Amy. Hi, my name is Blair, and I'm the director of the maternity program at PBGH. And I just wanted to give a really quick background. The Purchaser Business Group on Health is a nonprofit coalition of self-insured purchasers. So essentially, large employers and public agencies. We have about 40 members, and they cover about 15 million American lives, which generates about $100 billion in spend. So these purchasers are very engaged in improving healthcare, and you can see our mission here: advancing quality, driving affordability, and fostering health equity. PBGH is a little over 30 years old, and our maternity program is about 8 years old. We started off focusing on C-sections and then transitioned into focusing on physician-midwife collaboration in the hospital. And then we have recently been focusing on the health system collaboration with midwifery care in the community. So that is what led us to this great work with primary maternity care. And we're excited to have this great audience today to hear about this new guide that we've released. And hope that you will, as Amy said, join us later on in the year for our open learning series and action collaborative. So Amy, I'll pass it back over to you.
Thanks, Blair. So just briefly, a little bit more about primary maternity care, or PMC. We're about to have our third birthday. We were born right at the beginning of the pandemic. The first project we took on was to open an emergency birth center to respond to the first wave of the pandemic in New York City. And we now are an interdisciplinary team of about 10 different consultants working really across the system on a mission to enable integrated high-quality reproductive and perinatal care by strengthening systems for patient engagement, quality improvement, value-based payment, and community-based care delivery. So we have a lot of different clients, including enterprise clients like payers and health systems, as well as independent birth centers and small practices and nonprofits and startups that we've worked with over the last few years. And really our sort of specialty is in generating tools and programs to help implement these models of care and sustain them and figure out the financing and payment models that are going to allow them to stick and grow. And so when I talk about these models, it's primarily midwifery models. I have a clinical background as a midwife and a lot of operational experience in the birth center model specifically, but I've also practiced at home and in the hospital and done hospital quality improvement work. But we work with around doulas and home birth practice and community health worker models as well. So that's a little bit more about what we bring to the table, and we'll get back to Step Up Together, but I just did want to highlight one of our programs that really is part of the anchor of this work that we started doing with PBGH, which was around transfer and management of emergencies in community birth settings. So PMC has a program called Step Up Together that we run as a learning collaborative. So far, it's been with community birth practices. So we've had about 20 different birth centers or home birth practices around the country participate. And it's a train the trainer program where we provide a toolkit and a drill scenario and coaching and a learning community to allow these clinical leaders in these birth centers and home birth practices and a couple of community hospitals to run effective drills, manage those, debrief them, and turn them into improvement experience. So this is one of our, one of several programs that we have and have done with partners, and we'll talk about some ways that we're going to be growing that program through this work. I briefly want to talk about what a birth center is for the purpose of this conversation. We are talking about freestanding birth centers because the work that got us to where we are today really started around issues of smooth transfer, and also some issues around payment for the facility of that birth centers are. We've just been anchored in the freestanding birth center model. There are other models of midwifery care, and including a sort of in-hospital midwifery-led unit model that now has an accreditation pathway of its own through the Commission for Accreditation of Birth Centers. So I just wanted to talk about that and then acknowledge that we're talking about freestanding birth centers today, which really are both a type of facility and a model of care. And you can see this model of care on the right-hand side. It's a very, it's a real package of care that yields the positive outcomes and positive experiences that are associated with this outcome. So it's really supportive of physiologic birth, partner and family involvement, continuous labor support from continuous midwifery support and intermittent auscultation, hydrotherapy. So you can sort of see the whole package to come together. The package encompasses prenatal and postpartum care elements, which we go into much more depth about in the resources we'll be pointing to later in this talk. But just to anchor us in sort of what the model is at a high level, it's staffed and equipped for low-risk births. So these are vaginal births at term, head-down babies with people that have had low-risk pregnancies and are under continuous evaluation for their risk status to ensure that they remain low risk. Because they're giving birth outside and separate from the hospital building and supported by midwifery care. So typically there are not physicians in the building, and there are not cesarean suites or anesthesia capabilities beyond some birth centers have nitrous oxide and those kinds of things, but it's generally for unmedicated out of hospital birth from a really holistic wellness model that encompasses the birthing person and the family and acknowledges birth as a complex social, emotional, cultural, and spiritual, and so on event. So again, we point you to the resources, which we'll show you the links to momentarily here, where you can find a bunch of different ways to learn more about the model itself. But we want to kind of transition a little bit into why we think hospitals should be thinking about collaboration and integration. We'll be pulling a few quotes from the guide that we'll be talking about. This is one from a hospital leader who said, if a hospital is looking to meet patients where they are, I'm surprised we don't see more hospitals introducing birth centers as part of their service line. So that's what we're here to talk a little bit more about. Oops, excuse me. I'm going to pass it over to my colleague, Bryn, to walk us through why hospitals should embrace this model.
Thanks, Amy. So I'll try and be efficient, trying to getting through this list. You can see there's many reasons that we're seeing increasing interest from health systems in adopting and integrating the freestanding birth center. And so to help us digest those, we've divided them from 3 different perspectives, like thinking about how it benefits the hospital, how it benefits the community, and finally the system at large. Starting with the hospital, I think it's for most people on this call, they're aware of the growing demand for birth centers and just a wellness-focused, personalized prenatal care generally. In California Healthcare Foundation surveyed California mothers in 2018, and 40% indicated high interest or being open to the birth center model. So it's really meeting the demand of the growing demand of patients. The second is optimizing for services and resources across levels of care. Birth centers help hospitals meet the broad spectrum of risk and preferences that we encounter with patients today, and really help implement the levels of care as outlined by ACOG, ACNM, and so on. They also create a pipeline of ancillary and specialty services. Birth centers can provide a lot of care for the patients they serve. However, there will always be care that they cannot provide in the birth center. So whether that be labs, whether that be ultrasounds, really creates a business opportunity, frankly, for the hospital and health system to have a strong relationship with birth centers and to be able to provide those services to women in the community. And we know that up to 30% of births do end up in transfer to higher levels of care of birth center births, and having a strong relationship with birth centers during birth can really create a market opportunity for hospitals. And then really coming from the needs of the community, right? So as I just mentioned, we're seeing an increase in demand for out-of-hospital birth, and it's really the responsibility of hospitals and health systems to safely meet that need and prepare properly for increase in transfers and educate their staff. And that's doing right by the community, by community birth centers and patients. It's also, birth centers are an opportunity to build trust and invest in culturally responsive care for historically marginalized communities. Birth center care is relationship-based care, and it's delivered with keeping in mind the cultural identity and experiences of its patients. And so as a result, a lot of trust is built. And this trust, evidence suggests, is protective against poor experiences. And so investing and respecting that community-based model is a way to really invest in our communities. And then the systems investment, I think, again, we know that over 2 million women, or 2 million women are living in maternity care deserts in this country, with poor access to prenatal care or long drives to their labor and delivery unit. And community birth centers can really function as an ambulatory opportunity. Sorry, apologies for any noise in the background. I have twins downstairs. But an ambulatory opportunity for health systems to really be able to offer prenatal care in harder to reach rural geographies, because birth centers have a lower overhead to stand up. It really offers an opportunity to reach hard to access populations, and we've seen success in this model in other areas of healthcare. The transition to value-based payment, I think it's pretty well established. Birth centers are associated with good outcomes and can help hospitals and the system at large meet the value-based measures put forth by purchasers, such as preterm birth, lower C-section rates, and then finally supporting reproductive choice and autonomy. Hospitals and providers have an obligation to offer safe and respectful care to all patients, no matter whether, where, or how they decide to give birth. And we really need to start seeing care choices during birth as an extension of reproductive justice and autonomy. Okay, checking time. Moving to the next slide. So here's another. We cast a wide net for who comes to the birth center. Many of these folks would have never used our collaborating hospital for ultrasound labs or selected to have their care there. We estimate that 75% of our transfers are individuals who would have not delivered at the hospital if they had not come to the birth center. So really capturing the opportunity well for hospitals and health systems to further invest in partnership and collaboration. with birth centers. And the guide really dives into these value opportunities deeply. And we will shortly describe how the guide will also help hospitals and health systems identify the opportunities that are most relevant to their unique health system and unique community, and how to build an integration plan to accommodate these opportunities and these priorities. So why does integration matter? I think we covered some of this in what we were just talking about, but to be really specific and on the nose about it, seamless integration between freestanding hospitals and freestanding birth centers and hospitals promotes safety by ensuring transition and transfer of care between providers, facilities, and/or levels of care. It provides a cohesive experience and care coordination. Avoids the duplication of services with a cost-saving mechanism for the system. And it's an opportunity for growth, and it's an identified area of need. I think we all know that we have a lot of work to do to improve outcomes in this country, and there's a lot of research behind to suggest that birth centers are one of several opportunities to really move us towards better outcomes. And with that, I think I'm handing it back to Amy.
This is Blair. I'm going to take a couple slides for you. No problem. So thank you so much, Bryn, for that enlightening insight on why integration matters. And Amy touched a little bit on some of our work over the past couple of years to really dig into what is needed in this space. And she referenced that we held a technical expert panel that was focused on transfers in California. We also did a patient focus group and a focus group with birth workers. And we really tried to just understand what is the need, both from the provider standpoint and from the patient standpoint. And really, we understood that there was a gap in resources, that we needed to have better collaboration across the industry to truly have hospitals and the community operating as a system of care. And we heard from our patient focus group in particular that there, luckily there are some success stories out there, but unfortunately there are some traumatic and devastating stories of folks who are who have experienced a traumatic transfer, or who have felt judgment for receiving care in the community, who have then had to transfer to a hospital because their acuity of care increased. So what we, and you can go on to the next slide, please. So this brings us to what we wanted to put together, which is the Hospital Guide to Integrating the Freestanding Birth Center Model. I'll put the link in the chat for a moment. It's free to download, and you can see a lot of different resources on the primary maternity care site. But essentially, we didn't want to reinvent the wheel. There are a lot of great resources that have been developed in various parts of the country, including Washington and Utah and Oregon, British Columbia. So we've tried to pull together resources that have been created from other organizations, and then also fill in the gaps for what else is needed. So what you'll find is a very comprehensive guide, and we've broken it down into these 4 sections. So, if you're starting from the very beginning and thinking, I'm a hospital who, is starting at square one, I need to know just how do I work with midwives and birth centers in my community, then start at the beginning. Start with this assessing readiness for this birth center integration. Maybe you're a little bit farther along and you've already had some relationships that you've fostered over the years with midwives and birth center leaders. That's great. Then start to think about, okay, how do we partner? What does that look like? What does this collaboration look like? And we'll dig into kind of this partnership, ownership, understanding those integration approaches. And then in terms of how to, it can't just be a one-off, set up the relationship and then it stays going forever. You really need to think about joint quality management and maintaining this quality relationship and having ongoing check-ins. And then last but certainly not least, we live in a world where we need to think about finances. We need to think about sustainability. So we have a chapter at the end that focuses on the financial and business case considerations. So like I said, we tried to make this an opportunity for you to jump to where you need and where the need is for your organization as far as increasing hospital birth center collaboration. And I just want to emphasize that the PMC team and the PBGH team are here to help as well. So there's references throughout the guide for how you can reach out, but you can also reach out to us directly. And I'll put the link to the guide in the chat, but I'm going to go ahead and hand it over to Amy, who will dig a little bit deeper into some of the sections of the guide and what you hope to find. Thanks, Amy.
Yeah, thanks, Blair. We thought we would kind of show you one or two of the tools and a little bit talk a little bit about some of the insights that bubbled up with each of these sections. And Blair talked about some of the background in terms of the focus groups and technical expert panel, which we built upon that. But we also were conducting a lot of additional research as we pulled this guide together. So we conducted a national survey of birth centers that self-identified as having strong relationships with their health systems. And then we did dozens, I think, of individual interviews with birth center leaders and their hospital counterparts in a range of different kinds of relationships, both like independent collaborating, independent not really collaborating very well, models where the hospital owned. And so we really, spent the time, in addition to bringing our individual and collective experience to this, really like making sure this had the practical brass tacks, like this is what these partnerships actually look like. And here are some of the mistakes that we've made so we can, not have folks reinvent the wheel. So, and we also just wanted to celebrate and curate all the amazing resources that do exist out there. And like Blair said, we really saw that there is a need for resources, but there are resources. They just need to be directed to the right channels. And the place where we saw the most important gap was resources for hospitals that really spoke to hospitals in their language, addressed their concerns, and also really centered the birth center model and the importance of kind of the community, the way that the model is grounded in and driven by the community. So that's kind of some more of the context, and we'll just start to take a look at this. So again, we had all these great deep conversations and surveys that we fielded, and so we pulled out and put throughout the guide some of these quotes. So this is a doctor from who works with a birth center saying, talk about it like this. This is happening in our community. This exists, and we will receive these transfers. How are we going to do? What are we going to do about it? How will we collaborate to ensure we have processes in place for communication, for transfer and transport when it's appropriate and necessary? So, and this was a theme we heard from multiple people who talked about, like, if you could get hospital skeptics to switch from, do we really want this? Do we want these transfers to, like, these people are coming to our hospital, now what? And how should we be prepared for and responding to that? So that's just kind of a framing insight. And then the tool on the right-hand side is a stakeholder planning map. So we talk in the guide about figuring out who are those skeptics and who are the potential champions for the birth center model, and just who are the stakeholders who have reason that they're part of the system is going to touch this. So the obvious ones like the OBGYNs and hospitalist service, but also things like the marketing. This is just page one of a tool that goes on. So this tool helps you kind of organize who are the people in the neighborhood, if you will. What do they care about? both on the positive side, like what might interest them about this, whether that's, a revenue opportunity or, or some other reason why it might make their life easier, or a referral opportunity, as well as their concerns. What are they thinking about liability or competition or, adding complexity or whatever. So mapping those out. And, this along with some other checklists and materials that we have in this section of the guide, which is really about assessing readiness, help you do exactly that. Figure out, like, are we ready to go implement birth center integration, or do we have work to do on kind of getting people up to speed, maybe some more education to do with people about what this model is, or spending some time listening to some of the concerns from the NICU staff and those kinds of things. So that's an example of some tools, and that's in the first section. As Blair talked about, after we sort of assess readiness, there's questions that will come up around partnership or ownership. So we really recommend partnership as the kind of low-hanging fruit option, meaning an independent birth center. Many of them are owned by either midwives or small business owners, or there's starting to be some small networks of birth center chains, if you will. So that would be, independent from the birth center, but collaborating around transfer and referral opportunities. And so we talk about that versus other models, which we've also seen where hospitals either acquire an existing birth center or build one from scratch, which are also models that can make sense for some health systems. So we look at kind of a framework of how to assess these different options and then what some of the pros and cons are of them. One of the themes we really heard from folks, again, this is from a physician medical director of a birth center. It's important that the hospital not apply the rigid medical model toward midwifery care. You need supporting infrastructure that goes along with the birth center integration. So we heard a lot from about just the kind of disconnect and different worldviews that the birth center and the hospital come from that make them sometimes, misunderstood in both directions, but that when hospitals come in and acquire birth centers, for instance, they might not fully understand how the model is operationalized, or some of the components around how to get paid for it, because they differ in pretty fundamental ways from how all those things work in the hospital. Some of the tools that we provide in this section, or one of the tools, is a draft templated transfer agreement. So it was written really to help articulate the responsibilities of both the birth center and the hospital, and to mitigate or really get rid of the liability concerns that can come from having sort of an unclear relationship, or blurred lines around responsibilities. So so that's what we have in this model, and all of these tools. And I don't know if Claudia or someone is posting, but you can find all of these tools in the guide itself, which is a PDF download. And then these ones that PMC developed you can download directly from our website, and you can remix them and use, adapt them for your own practices. They were developed to be shared in that way. Establishing and maintaining quality is one of, I would say, the more robust sections of the guide. There's a lot of great resources for maintaining quality and being prepared for emergencies in community birth, including in birth centers. So this is a quote from a nurse leader in a hospital-owned birth center that had been conducting drills. As we got ready to open our birth center, we've been running drills as part of our orientation, and it's been a good way to build a relationship with each other and with our local EMS and fire department. So, and that's another really key constituent stakeholder in this, is the EMS and transport partners. So there's some resources in this part of the guide around how to engage EMS, including this whole toolkit of its own that actually PMC helped develop with the American Association of Birth Centers on coordination and collaboration with EMS. That includes some CE modules and some checklists and other tools for midwives who work in birth centers to really like understand what are the capabilities of the EMS teams and the other responders that might show up at emergencies. What kind of equipment do they carry? What are their training, and what does collaboration during that time of the transport look like? So those are planning elements that really need to be thought out and then tested through drills. So we talk about some of the tools and techniques for doing that. And we also have this really exciting tool that it's been fun to see people start to use it, an eligibility and midwife physician collaboration guide. So this is we'll show you, talk about opportunities to get a closer look at some of these tools, but this is a guide that helps you really establish kind of by going kind of line by line through all the different types of risk factors and conditions about what is appropriate for the birth center, you know, and eligible for the low risk birth center, what kinds of things require physician consultation to preserve eligibility for the birth center, and what kinds of things are appropriate for midwifery care in the hospital setting, and what kinds of things really need to be referred entirely to physician care. So as we get more examples of collaborative practice, we're hearing more and more from midwives across all settings that actually don't have a good understanding of where the edge of their scope of practice lives, and how, you know, and when to engage their physician partners and other members of the team. Birth centers actually are really advanced in this because the whole model hinges on eligibility criteria. And so birth centers tend to be actually quite good at continuously assessing eligibility and putting kind of plans in place for clarifying the right level of care for people. And so we built this tool to really take that, make it a little more structured, and extend it into midwifery in the hospital setting as well. And then in the financial and business case considerations chapter, again, we heard from hospitals and birth centers that that hospitals sometimes really struggle to, you know, to sort of realize the gains that they expected to realize when they acquired or went down the path of trying to open a birth center because of some, you know, misunderstandings around contracting and so on. So this is from an administrator from a birth center that had been acquired by a hospital, and everybody assumed the hospital would be able to get at least as good rates for because they have the sort of negotiating power. But they saw, in fact, that the opposite happened, and they said, we assumed the hospital would have the power to negotiate for better contracts. What stumbled them up was that the contract writers didn't realize what a birth center was. We'd fought hard for our original facility fees, but the hospital contract writer didn't understand that. So you do see sometimes that, like, birth centers, because they have to like fight and be so scrappy and, you know, really understand their model to be able to explain it to, for instance, contractors at a health plan. They, you know, when you have a health system doing the contracting and they don't, you know, understand a birth center and can't necessarily then advocate for it, you can have a disconnect. So we talk about, you know, some of those myths and realities and insights from birth centers and hospitals that have looked at both the kind of fee-for-service and value-based opportunities with birth centers, and how to make you know, make the whole model sustainable in these different types of collaboration structures. We wanted to point out another tool. This is another resource that Primary Maternity Care worked on with AABC, which is a white paper on getting payment right, and with a whole bunch of insights around how we can improve the financial sustainability of birth centers and decrease the complexity of the payment system overall. So we'll have time for some questions. So start thinking about what your questions are. Oh, it looks like we're already getting some, but we are excited to talk about what's coming next. So the guide came out a couple months ago at this point, at the beginning of this year. And later this year, this summer, we're going to be launching an open learning series. So we want all kinds of hospitals and birth centers and other stakeholders to participate in this. We will be providing CE credits for all different specialties. And really we'll be taking some of these tools as well as others and really taking a deep dive and in real time, sort of using these tools and doing implementation work with some guest speakers that we're going to bring who have like boots on the ground implementation experience in different types of partnership models. So we'll start with some foundational pieces and centering equity and birth justice, which is a big theme in the report. So we are going to be threading that throughout the series as well, but also having a special session on it. You can read the remaining sessions because I know we want to get toward questions here. But we will talk about transfer workflows and working with EMS and Sentinel events and so on. And then that will be available for everyone. And then we will be leading into a Step Up Together collaborative. So that's the drills and skills program that PMC has developed. We will be developing a version of that to enroll hospitals and birth centers together to plan, conduct, and debrief a drill that will start in the birth center and end in the hospital, either the OR or the NICU, whatever the scenario calls for, and that will actually travel on the emergency transport vehicle, whether that's EMS or whatever. So we will work with just operationally how to get something like that planned and executed and have opportunities for group learning and reflection so that everybody can kind of learn from each other's drill experiences. We'll be providing interdisciplinary contact hours for that as well. And through the grant that's supporting this work, we'll have scholarships and technical assistance for 6 pairs of hospitals and birth centers. And then the program will be open for others as well. And we're seeking some additional funding to hopefully open up more subsidized slots in that program. So that's what's coming, and folks that are interested to get on the list to be notified can send an email to our info@primarymaternitycare.com. I think that is our, oh, we just had one more quote real quick to kind of wrap it all up, that really the collaboration goes beyond the transfer patients, although that's critically important. We work at all levels to create a cohesive team from the birth center to all aspects of the hospital system. We do the work on the back end so the patients feel continuity when they need our services, and the midwife team trusts us to support the care they provide and create a safe environment when transfer is needed. So that was from a medical director of a birth center that was operated as a joint venture. And I just think embodies the spirit of, you know, we want people to feel like they're having one experience, even though their location of their care and the, you know, constellation of their care team might spread across multiple facilities and professions. So we'll stop it there, and I'll stop sharing so we can see each other's faces and I can get caught up on these texts.
Great. Thank you so much, Amy. And we're going to get to your questions. I just wanted to emphasize both the open learning series and the action collaborative. We really are looking for that to be a place where hospitals and birth centers can come together and learn together. We want this to be a place where there are no bad questions. There's a lot of, we know there's a lot of things that both sides want to learn about the health system and the birth center models of care. And we want to be there to support you as you work to pursue that collaborative model for your patients and for your community. And with that, Claudia, I know you wanted to take we've got a couple of great questions that came in through the chat. Please keep on sending them in. Claudia, I'm going to hand it over to you because I think you wanted to take one of our first questions.
Yeah, thanks, Blair. The first question was, what do you feel is the biggest barrier to insurance coverage and transparency for birth center clients? And I think that the biggest barrier that we identified in this work and in other work that we've been engaged with through the American Association of Birth Centers is really the lack of understanding on behalf of insurance companies that the birth center model, in particular the freestanding birth center model, is distinct from hospital-based service lines. And part of it is with verbiage. A lot of hospitals call their labor and delivery unit a birth center. And so when freestanding birth centers are trying to work with insurance companies to get contracts, sometimes they face a lot of confusion that they are a distinct service that really doesn't look very much like what the labor and delivery unit at the hospital looks like. And it's not duplicative of hospital-based service lines. It is unique and distinct. And so I think what we see is that education is needed, and resources like this and other resources that the American Association of Birth Centers has that really help with everyone to understand what the freestanding birth center model is. The next question was, what is the biggest barrier for hospitals to support and integrate independent birth centers? And there are many barriers. I'm sure each of us could come up with our own from our own unique perspective and lens. I think, again, one kind of overarching issue is education and understanding what the model is. And interestingly, when we had our stakeholder interviews, and what we heard both from birth centers and from hospitals is that there's a lot of misunderstandings on the hospital's part about what the birth center model truly is and what it looks like. And many birth centers said that they had more success once they were able to get representatives from the hospital, including physicians and people in leadership positions, actually in the door at the birth center and able to tour the facility, see the space, talk about what a patient journey looks like at their center, and really get them to understand how the model is similar but unique and distinct from what the hospital offers. And frankly, when people enter birth centers, you understand why someone would desire that model, and it challenges what a lot of people's preconceived notions were about the model when they actually walk in the door and see the facility. And it can be really transformative to have people have that experience.
Thank you so much, Claudia. I'm gonna I'll read through our next question, which is from Elisa Arabobo. Do you have any data on the cost of building a more integrated system? What were the unexpected pitfalls that you can share?
I'm happy to answer that one, and then Bryn, Blair, Amy weigh in as well. I think that we saw the cost could vary dramatically based on what that integration looked like. So if we saw that the integration looked like what we were describing with a partnership model, where you have agreements, not necessarily signed, but agreements in place that kind of outline some conditions. If you have, joint drills, if you do some quality work together, it can be, simply the cost of your staff's time to engage, but really highly cost effective and can serve patients extremely well based on that deeper integration that you have just across, clinical processes and administrative transfer processes. I think when you're going to the other end of the spectrum and full ownership, we did see in our stakeholder interviews that sometimes from what the hospital modeled while they were doing diligence about a potential purchase to being on the other side, having actually purchased a birth center and finding out that they needed to do a lot more integration than they anticipated. Things such as extending their EHR that they use in the hospital to the birth center. And originally thinking that maybe that wasn't necessary, and finding out on the back end that really that was necessary and was an expensive because of the new service line that they were adding. So I think that, it can be a large spectrum. It depends what that integration looks like. And one of the things that we highly encourage in the guide is to really think through all of the decision points. If an institution is considering ownership, think through all of those decision points and which direction they're going to go, and understanding those costs, and also understanding the decision, the right decision that protects the birth center model and leaves a freestanding birth center as it should be, distinct from labor and delivery, might be the more expensive decision, and that should be baked into the overall decisioning about the purchase or transaction.
Yeah, I mean, I would add to that. Overall, I think on answering the question about pitfalls and costs, I think we saw integration struggle when hospitals tried to apply their own policies and their own processes and expectations about throughput and how much money the birth center would bring in to the birth center model, right? I think this goes back again to understanding and really embracing the birth center model, but it takes a lot of effort on the part of hospitals who are, heavily regulated in a way that birth centers are not, to adapt their processes and make exceptions for birth centers. And that's really what's required in order to preserve the integrity of the freestanding birth center model and actually deliver the outcomes that we know we can achieve and meet the needs and expectations of patients and honor what that the birth center does have a trusted relationship with the community. And so I think it's a challenge, and it really goes against a lot of the ways we've been practicing the healthcare, or the way that the culture of healthcare we've developed. And we have seen beautiful examples where it does work, but it's intentional, like letting the birth center maintain its Instagram, after acquisition. Even though it is not a hospital branded or health system branded Instagram, recognizing that the institution does have a unique relationship with the community, and social media is a way to connect with the community. So I don't know if Amy, Blair, Claudia have things to add on that point, but I think that's important to highlight.
No, I thought those were great. I think I can take a couple of these other questions. I think somebody asked, are birth centers run by CPMs included or only CNM birth centers? I don't know if that means included in the Step Up Together program and the open learning series, but that's certainly for all types of birth centers, and probably even home birth practices would get something out of some of these programs. But CPMs work in and run the majority of birth centers, or they work in the majority of birth centers, and the ones that are owned by midwives, the majority of those are owned by CPMs. So it's really important to engage CPMs in birth center system strengthening work. So yeah, we absolutely talked to a number of them as part of this project, and they're welcome in the implementation of it. And then I also see one, any words of wisdom to how to get a birth center to talk to the hospital. The birth center is willing, or the hospital is willing and has reached out. I would say, I think our learning series, this guide, the Step Up Together program are all opportunities. So you might reach back out with these resources, or when we send out the announcement later this spring about how to sign up for the learning series, that would be another opportunity. So I think I would recommend that, even though it's a little self-serving, but I would just acknowledge that hospitals really sit in a very powerful position with birth centers, and birth centers have sort of existed on the margins of our healthcare system out of necessity, and really sort of fearlessly stewarding this model of care that, frankly, they've had to kind of fight against the system. So skepticism of approaches from the hospital, I think, are a little bit natural. There are also quite a few examples of hospitals expressing interest in a birth center, and then ultimately leading to the closure of that, acquiring a birth center and then pretty quickly closing it after that. And so again, skepticism is common, and I think the guide really seeks to put a lot of ideas in folks' head around ways to engage that are more mutually beneficial and partnership oriented. And so I would encourage you to explore those. Yeah, thanks for somebody pointed out that CPM practice varies quite a bit by state. So obviously in states where there's not legal CPM practice, you're not going to find very many of them in birth centers. I think there was also a question about home birth practices. I'm sure there are some home birth practices that have transfer agreements that are similar to what birth centers have. I think it's more typical that home birth practices have physician that they, or a midwifery practice that they can transfer into, and that might be either formal or informal. But yeah, a lot of the tools in this guide are very relevant to home birth practice as well. But it's something like 90 pages, so we had to keep it focused and where we could. I want to acknowledge the time and maybe hand it back over to Deborah to wrap us up.
Yeah, thank you so much, Amy, Claudia, Blair, and Bryn. And it's been a wonderful panel discussion. Thank you all for attending and for your excellent questions. This session was recorded, and we will be posting this webinar on our website. It's free to access this webinar and to share this out with others. And we'll also include a link to Amy's organization and also to the guide. So we want to spread this word wide and far. So thank you again for attending today, and thank you for the PQI team for all the support you did to make this webinar go well. So thanks. Goodbye, everyone.
Thank you,
everyone.